Hi, it's Dr. Nick Tulo. Welcome to my clinical live stream here Sunday morning. It's around noontime in New Jersey, and I'm very happy that you were able to join me. These clinical live streams are a new idea for me, so please forgive me if things don't work out. It's actually really complicated to make sure everything is all set up, and it's not just my iPhone kind of staring at it and talking. There's a little bit of preparation, and but I wanted to share my clinical experience with you and bring the ECG information into more of a clinical realm. So talk about case presentations and treatment of arrhythmias that hopefully will give you a better idea of what to do with your patients. So this is a case presentation, and we'll get right to it. So this actually was a 76-year-old gentleman who has a history of coronary artery disease. He actually had bypass surgery like 20 years ago, but he'd been very stable since then and had no complaints of chest pain or lightheadedness or palpitations. One of my partners had been taking care of him for many years, and he'd been actually on metoprolol, getting 50 milligrams twice a day for high blood pressure and for some other things. And his rhythm was always fine, although he does have a chronic right bundle branch block. So he presented with chest pain. He had been having chest pain kind of on and off for a day or so, and he came to the emergency room with a sense of chest pressure and a little bit of shortness of breath. And let's take a look at his ECG. So anyone who is experienced in ECGs can actually see that he has some abnormalities here. Let's see if we can draw on our ECG. So we do see upright P waves in 1 AVF with a heart rate that's around 70 beats per minute or so. And we can see evidence of that right bundle branch block pattern in V1, that RSR prime, and we can also see wide S waves in lead 1 and AVL. So that's a pretty typical right bundle branch block. But as we look at the anatomical regions of the heart, looking at 2, 3, and AVF, it's pretty clear, and anyone who knows how to read ECGs or with any experience at all, that there's ST segment elevation here. So you can see it pretty well in 2, but especially 3 and AVF. He has at least 2 or maybe 2.5 millimeters of ST segment elevation. And you could even look at V2 with a tall R wave and very little S and some ST depression here, and that may be even a suggestion that the posterior wall is involved. Looking at the lateral leads, 1 and AVL look okay, but V5 and V6, there's again a little bit of a hint of ST segment elevation. So if you're working in the emergency room and you see this, particularly in a patient who has chest pain, this is consistent with the diagnosis of an acute inferior wall MI. And you might even say there's a posterior extension because of the ST segment depression in V1 and V2. So he was actually brought to the cath lab acutely. And what they found was that he had a bypass graft to a posterolateral branch that fed the inferior wall and a little bit of the lateral wall. But that graft was just chock full of clot. It had obviously developed atherosclerotic lesion in it, and it got corked off, and lack of blood flow caused the infarction. But there was so much clot, they really couldn't get it open. It was just not really revascularizable. They couldn't put a stent or anything. So he was hemodynamically stable at that point, and his heart rate was okay. And so we decided, since he was pain-free by that point, that we would just treat him conservatively, given the fact that his cardiac function had been normal. In fact, we got an echocardiogram afterwards, and his left ventricular function remained fairly normal. So even though he had this occlusion of a bypass graft and he made some enzymes, so he had an ST elevation MI, he didn't actually lose a lot of myocardium. But I was reading ECGs the next day, and this is the ECG that came across. And this is kind of what piqued my curiosity. It looks slower than the previous ECG. Remember, the previous ECG was running about 70 beats per minute. This is more like 45 without spending time to measure the rate. But the other thing that you notice is that, first of all, it is very regular. We could get calipers and check it, but trust me, it's regular. And although you see what looks like a P wave in V1 in front of that beat, and initially we thought maybe it was a sinus bradycardia, there wasn't a P wave in front of this beat. And there didn't seem to be P waves in front of most of the other beats. So the ECG machine read it as a junctional rhythm. And I said, why is there a junctional rhythm? Why would somebody develop a junctional rhythm in the throes of an acute MI, actually 24 hours after an acute MI? So you guys know that the inferior wall is most of the time supplied by the right coronary artery, but the right coronary artery can also supply the AV node. So in the middle of an acute MI, it's not uncommon to see various degrees of AV block. So since it's affecting the AV node, you usually expect to see a type 1 kind of a pattern with progressive prolongation of PR interval, like a winky back type of a pattern. And it can get to be pretty severe. And in fact, it's not unheard of to see complete heart block transiently, because it's almost like in a picture of ischemia of the AV node. But this is now 24 hours later. He was doing fine. His blood pressure was okay. When we saw this slow heartbeat, and of course the first thing you think of is, oh, he's getting all this metoprolol. Why don't we get rid of that and see what happens? So the metoprolol was held, but it's kind of like, this is one of those things. I'm a Big Apple guy, and I used to go to the Apple conferences every year, Macworld. And I used to watch Steve Jobs give his presentation when he first introduced the iPhone and even the iMac. And he always used to sort of save something special for the end. He'd always say, oh, and by the way, there's just one more thing. And what I thought was interesting is when I tried to figure out where the P waves were, I noticed that the baseline was very jiggly. And it turns out that he had developed atrial fibrillation. So this thing is not a P wave. It's actually just a bump in the road. The rest of this ECG is consistent with atrial fibrillation. And no one had noticed that before. Actually, you could see it on the monitor on telemetry. You can see these little fibrillatory waves. So it was like, here he is now. He's 24 hours after a myocardial infarction. He's developed atrial fibrillation, but his PR interval wasn't bad before. Why is he conducting so slowly here? So we thought, okay, well, maybe it's just the inferior wall affecting the AV node and causing AV block to some degree. And now what you have is a junctional escape that's occurring in the face of complete heart block. But 24 hours after an MI, it didn't make sense. So anyway, we looked at this monitor and kind of followed him over the next day or two. He wasn't symptomatic, by the way. He had no idea that he was in atrial fibrillation, in fact. And I started to ask him, well, did you ever have like dizziness or lightheadedness? And he said, well, a couple of months ago, he actually sort of passed out suddenly. He was standing in his kitchen and suddenly found himself on the ground, It's like, very interesting. Now, keep in mind that the escape rhythm has a right bundle branch block, and it looks exactly the same as the previously conducted beats. I mean, here's the first one. Notice that the axis in the frontal leads is isoelectric in lead 2. So if you remember, lead 2 is 60 degrees above the horizontal, heading down and towards the patient's left. So this is a little bit of a left axis deviation of -30, but it's not far enough to be an anterior hemiblock. But this same ECG configuration is present here in this ECG that has the atrial fibrillation and complete heart block. That's why I say it's a junctional escape, because it's conducting with the same QRS configuration as the rest of it. Notice also that the STs are coming down. He only has maybe at most a millimeter of ST elevation, and he has sort of a negative deflection here. Maybe he's developed a Q wave there in the inferior leads, but let's see what happens after that, because the first thing we did was we stopped the metoprolol, and we kind of watched him. Now, I went back in the next day off metoprolol. This is the rhythm strip that I saw. And it's really kind of interesting because it's a lot faster now. Now here's a QRS that lands on a heavy line. So now it's above 75 beats per minute. It's probably about 80 beats per minute. But it's very regular, and if you look on top of the T wave, you see a very sharp bump here, and that looks like a P. Although the PR interval now is a lot longer than it was before. It's probably about 240 or 280 milliseconds. So what he's developed is a sinus rhythm at 80 beats per minute with a first-degree AV block. But his AV node is now back to conducting 1-to-1. But then a few hours later, I looked, and the nurses called me that his heart rate suddenly dropped, and it was like in the 30s. I was like, what? What happened there? In the 30s? How could that be? So here's his ECG just a couple of minutes later. Now I've noticed that QRS complexes look the same. They're a little bit wide because he's got this little bit of a bundle branch block. But notice he's back in atrial fibrillation. You have these fibrillatory waves here that you really can't miss, but the rate is so much slower. But he's not in complete heart block now. I mean, even though you've got these really long pauses here, how long is this? 2, 3, 4, 5, 1, 2, 3, 4, 5, 1, 2, 3, 4. It's over 3 seconds. But he has shorter intervals, and here's a very short one. So the AV node is still conducting very slowly, but it's not complete heart block at this point. But why should the AV node? It was conducting 1-to-1 just a minute ago. And now all of a sudden you've got these dramatic bradyarrhythmias. Why do you think his AV node suddenly failed? Why? Because don't forget, when you're in atrial fibrillation, your AV node determines how fast your ventricular response is. And he was just conducting 1-to-1 just a minute ago. And he went into atrial fibrillation, and suddenly he has what looks like high-grade AV block. Very, very long pauses, and but it's only happening in atrial fibrillation. And this started happening he was going in and out of paroxysmal atrial fibrillation. And when he was in a normal rhythm, his heart rate was like 80, because we had stopped the beta blocker, and maybe he even had a little bit of a beta blocker withdrawal, like a rebound tachycardia. But then he'd go into atrial fibrillation, and suddenly his ventricular response would be like in the 40s and 50s. It was really interesting example of concealed conduction. All right, how many people knew that? You knew the answer? Concealed conduction is an electrophysiologic phenomenon, and in particular when we're dealing with the AV node, basically it refers to the fact that when the AV node is bombarded with rapid signals, it conducts worse. And there's another name for that. We call it decremental conduction. It has to do with the fact that the AV nodal cells are firing because of calcium currents that are rushing into the cell. So they behave differently than the sodium-dependent tissues like the atrial myocardium, the ventricular myocardium, the His bundle, and the bundle branches, those, you've got that very rapid phase 0 upstroke, that you have rapid sodium currents running into the cell. So those sodium-dependent tissues, they're that all or none thing, right? We talked about this in a prior video. Calcium-dependent tissues include the sinus node and the AV node, and they're sort of known as pacemaker cells because they do fire at faster rates. So the sinus node is usually the primary pacemaker of the heart, and the AV node will take over. It fires at rates in the 40s most of the time as an escape rhythm. So those calcium-dependent pacemaker cells exhibit decremental conduction, and in particular the AV node. The faster you stimulate the AV node, the worse it conducts. And the reason is because of something called concealed conduction. What is concealed conduction? So if a signal gets down the AV node, it comes out the other end, down the His-Purkinje system, and you get a QRS complex. Concealed conduction is a situation where a signal gets into the AV node only part way, and then the signal kind of dies. It may be because the AV node was partially refractory. It may be because the AV node isn't conducting well. For whatever reason, anyway, we were talking about concealed conduction. So with concealed conduction, if the signal penetrates partway into the AV node, it leaves the AV node refractory. Those cells depolarize, and so when the next signal comes down, it encounters refractory tissue again. So you can have multiple signals that never get through the other end. And so the net result is that the AV node conduction is really poor. And this is what's happening here, is that you've got this rapid atrial rhythm that's going down the AV node, and it's suddenly conducting very, very, very slowly. In essence, what happened was this was not going away even though we stopped the beta blocker, so the patient wound up with a dual chamber pacemaker. So that when he goes into atrial fibrillation, his ventricle would be paced at a normal rate, and when he's in a normal sinus rhythm, the pacemaker would make sure that AV conduction was intact, and it essentially solved the problem. So this is the idea of concealed conduction is a really important concept in electrophysiology, and you should be able to recognize it as the reason why heart rates during atrial fibrillation tend to be much, much slower than they are in sinus rhythm, and even in atrial flutter to some degree. Because you can see a patient who goes into atrial flutter with an atrial rate of 300, and they can conduct 2 to 1 and have heart rates of 150. But if they go into atrial fibrillation, then suddenly the mean heart rate will drop to maybe 110, maybe 120, something like that. So that's a very common example of the evidence of concealed conduction. I'm losing my train of thought because I realized that I wasn't live this whole time. And I apologize to anyone who was waiting. I'll get it right one of these days. But this video will post to my channel, ECG Doc. So if you go on YouTube, I will post the video in its entirety because luckily I've been recording it. And so you'll be able to watch this video within a little while if you go on my ECG Doc. That's my YouTube channel. I promise next time it's gonna work. This is the 5th time that I've done. This is the 4th time that I've done it, and you have no idea. You really need a producer here to press the right buttons and make sure everything's working. But anyway, I hope you enjoyed this discussion. And yes, the patient got a pacemaker, and he did really well. And next time, I hope that I can present another case and another really cool discussion of the ECG changes and arrhythmias and the complex ideas that maybe you don't get in your basic ECG class. And if you really like this content, or if you'd like to learn more, you can always go to my website, which is ecgacademy.com. There's actually a link in the description. If you scroll down to this description, you'll be able to click on it. And I have a whole entire course that talks about AV conduction and arrhythmias and concealed conduction. And you can do basic or you can do advanced, and you can even earn some credits if you are a nurse practitioner or an RN. So I thanks for watching this this live stream that was only live for the last few minutes, but I'm going to make sure that I post this video on my channel. So go looking for it, and I think you'll enjoy it. But until next time, this is Dr. Nick Tulo. Thanks for tuning in.